Hi, this is Brandy from Mana Health Partners. I'm bringing you another educational video from our series, and this one is on evidence-based practice at the point of care. So a lot of nurse practitioners are either new to the field or they haven't had a lot of experience, specifically in skilled nursing facilities. On the other hand, there are some autonomous nurse practitioners who have been practicing for a while, but may not be a practicing NP in this setting and are new. This presentation is for all of you because prescribing safely in skilled nursing facilities takes a little extra thought and understanding. So before we dive in, let's take a look at what we're going to cover in this training. We'll start by reviewing the scope of practice and the role of the nurse practitioner in the skilled nursing and long-term care environment. From there, we'll look at the prescriptive authority and the legal guardrails that define how and what we can prescribe in this setting. We'll explore how to integrate evidence-based clinical tools and apps into everyday decision-making. Because safe prescribing isn't about guessing, it's about using reliable, accessible resources at the point of care. We'll also cover lab ordering and medication monitoring protocols, when to order, how often, and why it matters for patient safety and regulatory compliance. Then we'll bring it all together by discussing antibiotic stewardship and how together we use McGear's criteria in unison with Interact care pathways to guide appropriate evidence-based treatment decisions. We'll go over the before you prescribe algorithm to create a consistent clinical thought process and highlight some of the most common prescribing pitfalls we see in this environment. Finally, we'll wrap up with documentation and regulatory considerations, and I'll share some additional resources you can use after this training. At the end, my information with my contact is there, and so I welcome any questions or concerns or any feedback that you may have. Throughout this PowerPoint, you will see many URLs. This is where I got this information from. So most of what I took was from the Florida legislation, the Florida Board of Nursing, Florida Autonomous Nurse Practitioner, Florida Nurse Practitioner guidelines. So that's where I'm getting this information. This isn't something that I've just tried to comply or pull up together. This is actual legal precedence on how we prescribe, and we do our due diligence in writing prescriptions. When we talk about the role of the nurse practitioner in this setting, we're really talking about the heart of what we do every day. This is why we have facility nurse practitioners Monday through Friday. As nurse practitioners in skilled nursing and long-term care, we're responsible for managing selected medical problems, those conditions that fall within our training and within our scope of practice. That means we can order diagnostic tests, initiate appropriate therapies, order PT, OT when clinically indicated to support patient recovery and function. We also have the authority to initiate, monitor, and alter therapies for certain uncomplicated acute illnesses, things like mild infections, respiratory illnesses, or pain management when appropriate. A big part of our role is to monitor and manage patients with stable chronic conditions, such as hypertension, diabetes, COPD, and depression, as well as behavioral health conditions that have an established diagnosis and treatment plan. This scope allows us to intervene early, keep patients stable, and often prevent unnecessary hospitalizations. And it's all grounded in evidence-based practice and Florida's nurse practitioner practice authority. This slide is the cornerstone of what we do as nurse practitioners. It outlines the legal guardrails for prescribing across acute, chronic, and preventative care. In Florida, nurse practitioners can prescribe, dispense, administer, or order any drug within the limits of their scope and licensure, and when applicable, under a collaborative agreement. Here's how that care translates into practice. Acute care. When a patient presents with a new or worsening issue, we can prescribe short-term treatments like antibiotics, steroids, or other appropriate therapies, as long as we document clinical justification and stay within regulatory boundaries. For chronic care, conditions like diabetes, hypertension, COPD, CHF, seizure disorder, and in pain management, we have the authority to initiate, titrate, and maintain ongoing medication regimens. This requires monitoring labs, following evidence-based protocol guidelines, and staying aligned with DEA requirements when controlled substances are involved. We can order vaccines, vitamins, supplements, and screening labs like lipid panels, A1Cs, thyroid levels, as part of remaining or maintaining or improving baseline health. The big reminder here, prescribing isn't just clinical, it's legal and regulatory, especially when controlled substances and your DEA license, state regulations, and documentation are non-negotiable. That is why understanding your scope of practice and prescriptive authority is critical before you even start to prescribe. When we talk about managing selected medical problems, we're talking about what lies at the core of nurse practitioner practice in Florida. Under state law, nurse practitioners have the authority to diagnose, treat, and manage common acute, chronic medical conditions that fall within our training, scope, and certification. That includes ordering diagnostic tests, therapy, initiate, monitor, and alter therapy for uncomplicated acute illnesses, patients with stable chronic illnesses, and really understanding what that represents. So routine screenings, immunization, vaccines, counseling, very important on lifestyle, nutrition, exercise, smoking cessation, and sleep hygiene prior to medicating, the risks, early detection of diseases, and then not only that, but putting diagnoses and treatment plans together. When we talk about prescriptive authority, it's important to remember that not every NP will be at the exact same level of practice. Some of us are autonomous and some of us are just starting out. That's okay. The legal guardrails are there to support safe prescribing no matter where you are in your practice journey. Under Florida law, nurse practitioners can prescribe both non-controlled and controlled substances, but with very specific limits. For controlled substances, particularly Scheduled II medications, there's a 7-day maximum for acute pain. It's 3 days for acute and 7 days for non-acute. If it goes beyond that, there must be a clear documentation, justification, and alignment with state and federal regulations. Every nurse practitioner, regardless of status, must check the PDPM e-force before prescribing controlled medications. This is required by law and is a critical patient safety step. Download that into a PDF and put that under the miscellaneous records. That verifies that not only did you check it, but you uploaded it into the patient's charts. For autonomous nurse practitioners, there's a little more flexibility, but the same standards of evidence-based practice and documentation apply. The bottom line is, prescribing just isn't about signing your name on an order. It's about making sure that the treatment is clinically appropriate, clinically, legally compliant, and defensible. On almost every slide, I've listed the references on where I get this information. Again, this is all an educational PowerPoint with all of the references either as a URL or where I found this information from. Now, I did say there's a 7-day max for Scheduled 2. We'll talk about that in just a minute. But Scheduled 3, 4, and 5 also have restrictions on them as well. So while yes, you can do a 30-day supply and you can do a refill, remember, not only are we prescribing, but we're making sure that it's clinically appropriate, competent, and defensible. This slide is really important because it highlights exactly what we do as nurse practitioners, what we're legally authorized to do when it comes to medications, including controlled substances, as long as it's within our scope of practice. Now, in our specific setting, we don't typically dispense or administer medications ourselves. That's handled by nursing and pharmacy. But it is critical that we understand that our name is attached to the prescription. That makes us responsible for ensuring it's clinically appropriate and legally compliant. When it comes to scheduled narcotics or other controlled substance, a valid DEA registration is required. And that doesn't just mean holding a DEA number, it means understanding and following the federal DEA prescribing guidelines. These guidelines include correct indication and documentation, appropriate quantity and duration, mandatory PDMP checks, and proper follow-up and monitoring. Even though we may not physically hand the medication to the patient, we are the initiating prescriber, and that carries legal responsibility. I know this slide is a little busy, but the reason for that is simple. When it comes to pain management, there is a lot of responsibility on the prescriber. If we make the decision to start a patient on a medication for pain management, especially a controlled substance, we need to be fully prepared to support that decision in the medical record. That means 3 big things. First, we need to have clear medical indication. The reason we're prescribing the medication needs to be explicitly documented. That's what protects both us and the patient. Judicious documentation, including a history, assessment, rationale for starting the medication, and why it's appropriate at this point in the plan of care. And then a monitoring plan. Evaluate how we're going to assess the patient's response, evaluate effectiveness, and then monitor for any signs of misuse, abuse, or adverse effects. In addition, we should be thinking ahead. What's the exit strategy? How often are we reassessing pain? Are there any non-pharmacological options or lower risk alternatives? Pain management is clinically appropriate and necessary for many of our patients, but it has to be done thoughtfully, intentionally, and defensively. So before you do any kind of pain management, you're going to want to do a complete medical history and physical. The medical record that you're documenting must, at a minimum, document the nature and intensity of the pain, current and past treatments for pain. If you're starting right off with oxycodone because the patient has said that they've done a lidocaine patch in the past or that Tylenol doesn't work, do we really have current and past treatments that we have tried, not in the past for the patient 30 years ago, but what we have tried right now? We need to identify underlying or coexisting diseases or conditions. That could even be the use of benzodiazepines with a patient on new ordered opiates. The effect of the pain on physical and physiological function, a review of previous medical records, previous diagnostic studies, a history of alcohol and substance abuse. If you have a former addict or even a recent addict and you start a patient on oxycodone, what is the likelihood of you making not only their substance use disorder worse, but being unable to remove that medication once you initiate it? The medical record shall also document the presence of one or more recognized medical indications for the use. A written plan for assessing each patient's risk of drug-related behaviors, including potentially drug testing. And then we're looking at their plan. So when you're documenting, the patient has pain, 10 out of 10 will initiate Percocet. Is that appropriate documentation when we are initiating a new Scheduled II narcotic? So this portion of the white, the location of the pain, the frequency, the duration, the intensity and severity, the quality and character, the onset and course, the aggravating factors, the relieving factors, the associated symptoms, the impact of function, the interventions, and the response. We have pain management teams in place for just this reason. The last thing we want to do is be in charge of someone on pain management or be involved in a secondary nature. So for controlled substances and pain management, the best thing we can do for both patient safety and provider protection is to make sure there's only one prescriber that's managing the patient's plan of care. Pain management should follow the patient, meaning the designated pain management provider is responsible for the evaluation, dose adjustments, and refills. As nurse practitioners in skilled nursing and long-term care, our role is to support the plan, not to create multiple layers of prescribing. That means no refills unless absolutely necessary. That should be part of pain management. You shouldn't be doing a refill every single week and then not doing any of the rest of that. So this location, frequency, intensity, quality, character, if you are writing a refill, you are going to be documenting a complete assessment of this patient's pain, how they have done regarding the pain medication thus far, how they are with their pain and their pain plan, and what we're doing to get them off of that medication. So it's not necessarily that we're just writing a refill prescription. That's why pain management is on call 24 hours a day. No dose adjustments unless you are the designated pain prescriber and it's clearly indicated. Avoid multiple providers prescribing for the same patient because that's where things go wrong. Having too many hands in the pot doesn't just create confusion, it increases the risk for medication errors, diversion, and regulatory red flags. Keeping pain management with one provider keeps the plan consistent, traceable, and safe. I know that as a PMHNP, if I am adjusting someone's substance use disorder medications, such as buprenorphine, and they also have opiates, I am the first one on the phone with the doctor to say, are you in or am I in? Because we both can't put an opioid antagonist and an opioid agonist in place. So I collaborate with that provider. That being said, I'd prefer not to be involved altogether. So having one person manage this is really what is going to help the patient in the most effective way. That doesn't mean that when you're doing your monthly evaluation, you can't reevaluate the location, the frequency, and determine that the patient is stable at that time or not, and we need to get pain management back involved. What it's saying is that we should not be writing the prescriptions for that. So prescriptions of Scheduled II narcotics are very specific and very legal documentation is required that we have to follow. So if you're writing a script For Scheduled 2 medication for non-acute pain, it must clearly state non-acute pain. That's not optional. It's required under Florida law. You must also document the exact number of pills being prescribed, and it's within the 7-day limit for either acute pain or non-acute pain. So if they're allowed 4 pills a day and they have 7 days, that's the max you can order. It's 7 times 24, 7 times 4. That's the most you can prescribe for that patient. There's no refills that are associated with that Scheduled 2. And here's a critical caveat for our practice setting. Only a PMHNP can prescribe Scheduled 2 stimulants. So while a psychiatric Scheduled 2, such as Ritalin, Adderall, Vyvanse, are not subject to the 7-day limit, they are subject to being administered and ordered by a PMHNP. So if you have anybody that needs a refill of Adderall, anyone that needs a refill of Vyvanse, that is not within your scope unless you are a PMHNP. It is a Scheduled 2 narcotic. Now they do have other medications that you can use, but if we are talking about those medications, that's where your 24-hour-a-day PMHNP comes in, is to write those prescriptions for you. This is a really important slide because it gets to the heart of how we make our clinical decisions. How do we know which medication is the right one for a patient? It's not about what we used to do 5 or 10 years ago. Medicine is constantly evolving, and so should our practice. We don't rely on what worked for the last patient. We rely on evidence-based practice. What most appropriate research says now, backed by the most current research and clinical guidelines. That's where these clinical tools and apps come in. If you're not using at least a few of these resources, you're prescribing harder than it needs to be. These tools simply simplify your workflow, make your work more accurate, and most importantly, they help prescribe safely. They can give dosing recommendations, interactions, contradictions, renal and hepatic adjustments, and guideline-based treatment plans at your fingertips. This is how we stay current and protect our licensing while giving patients the best care possible. We're not expected to know everything. We are expected to know how to find that. So I have my phone, and on my phone have multiple apps. I don't use the same apps as everyone else. There are a lot of different applications. I've listed a few, like Lexicom, Up to Date. A lot of people like Up to Date. It's not one of my favorites. Sanford Guide, the EMR ABX. That is one of my favorite apps on my phone. Micromedex, IDSA, the CDC guideline, mobile research. So there's a whole bunch of mobile apps that you can use. What I'm seeing, and I'm just looking over here, is that I have had a nurse practitioner order a Z-Pak 500 milligrams a day for 7 days. You won't find that in any of these applications. You won't find that as evidence-based practice. So when a doctor comes behind and discontinues that and then puts 500 milligrams for day 1 and then 250 milligrams day 2 through 5, they're following evidence-based practice. Now, they may know that off the top of their head. You may know that off the top of your head. But again, going back to the apps so that we can look that up, verify that information, and make sure we're doing the right thing for the right patient, for the right diagnosis at the right time. One other was a patient that had a culture and sensitivity, and they were susceptible to Cipro and Levaquin, not the best drugs, and Rocephin. And so the nurse practitioner ordered Rocephin 1 gram IM for 10 days. We have Cipro and Levaquin at our fingertips. Oral is always going to be better than IM or IV. And while Cipro isn't the greatest drug to use, the last thing we want to do is create a superbug or something that is not responding. So another example that I saw was amoxicillin 500 milligrams twice a day. And the patient had a pneumonia. And so amoxicillin, if you look in any of these resources, amoxicillin would be given 3 times a day unless we're talking about a patient with end-stage renal disease or a GFR of less than 30, so chronic kidney disease stage 4. And then you would potentially do it twice a day. But bacterial infections, sinusitis, pneumonia, amoxil should be administered every 8 hours. When we under-medicate a patient, we help create or initiate a superbug. So by using evidence-based research, whether it's the Hippocrates or the EMR ABX, any of those, we should know the correct dosing for whatever our diagnosis is. This is where if we don't have it within our scope and we don't know the answer, we tap in the physician. Now, only when it's above your scope of practice would you really need to collaborate intensively with a physician. And I do recommend collaborating with a physician on a regular basis for those patients that are sick or are not within your wheelhouse, so to speak. Those that are outside of the scope of practice, those that you want to run some things or ideas off of, those that don't have one chronic illness but 8, and so we're trying to manage a cardio-renal, pneumonia, COPD, CHF patient. So I can see where it's very important to tap in a physician and collaborate with him. But make sure we've got the information that we need to provide him with the ability, or the physician, not him, the physician, the ability to help make us make those decisions with us. So here's one, for example, is Lexicom. Everyone knows Wolters Kluwer. Everyone that went to school, we had to use these books. They actually have an app you download it on your phone. It's used for adult pediatric. It's got the renal dosing, the drug-to-drug interactions, lab monitoring, adverse effects, off-label dosing with supporting evidence levels. And why is it trusted? Because it's regularly updated, it's peer-reviewed, and remember in your chain of reviewing your evidence-based practice, what is the most or the highest level of evidence? It is our peer-reviewed or random controlled trials. Those are what is most important. So this is a peer-reviewed app that they're using, and they're using it in hospitals and nurse practitioner programs nationwide. There is the URL if you want to log in and download that. Microdex is an IBM. Here's what the logo looks like. It has precise dosing by indication and route, black box warnings and contraindications, evidence grading for off-label uses, IV compatibility, pediatrics. That's not our wheelhouse, but geriatrics certainly is. And why it's trusted? Because it's used by major hospital systems and it integrates well with EHRs. Are we going to integrate it? Probably not. But putting it on your phone and having it at your fingertips may be a great idea. Up to date, again, not my favorite. I don't really utilize this a lot. I did when I was in school. but clinical decision support with guideline integration. So using it for condition-specific algorithms, that's one thing that we need to focus on, is the algorithms when we're putting new interventions in place. So UpToDate does utilize that. They've got summaries, they've got references. A lot of it is just articles, in my opinion, and I want a quick answer on what medication I need to put in place, what's the dose, and what is appropriate if they have any kidney or liver issues. So why it's trusted, it's peer reviewed, it's frequently updated, and it's widely cited in nurse practitioner practice and academia. Everyone uses UpToDate and cites it. Epocrates, I've got it on my phone. I was going to say I think it's free. It might not be, because I might have just gotten a bill for it. I love Epocrates. I can look up any medication. I can see when it was no longer allowed in the United States, where it is FDA approved, when it is getting FDA approved, what it is FDA approved for. So if you've got a medication such as trazodone and it's not FDA approved for insomnia, do not utilize the diagnosis insomnia. It is depression with insomnia, because depression is what it's FDA approved for. So I love my Epocrates. It's easy to use. Oh, they do have the premium version. I think I have the premium. It's a really good app for me on my phone. This is by far my favorite, $9.99 per year. It is the best. You can go onto the App Store and click onto it. When you open it up, there is a list of all of the different systems. When you click onto the list of a system, let's say you click on GU, it will bring up another list, and that list will have different GU infections. Then you click onto that and it will say if you have a urinary tract infection, if you have a complicated urinary tract infection, and it will give you that list. So it's one of my favorite tools for quick empiric antibiotic decision making. It's designated for emergency medicine, which makes it fast, clear, and clinically practical. For a nurse practitioner in long-term care or primary care, that's a huge plus, because we're often making antibiotic decisions at point of care, not after an hour of research. So there's no research. You click into it and it gives you evidence-based practice and then cites the source. So with EMRA, you can quickly find first-line and alternative antibiotics. So if you've got allergies, common pathogens and typical coverage, which is incredibly helpful in long-term care associated infections such as UTIs, pneumonia, or skin and soft tissue infections. You can see standard dosing and you can see renal dosing right in the app. It gives you a sense of what's evidence-based and guideline aligned, instead of relying on old habits such as give a Zithromax or give a Z-Pak. This app is not meant to replace clinical judgment, nor are any apps, but it supports rapid, appropriate, defensible prescribing. And I will sometimes take the medications from here and go back to Epocrates and make sure that my answer is the same. I'm always double and triple checking. Why? Because a patient's life is on the line. So pair this with Magear's criteria and interact pathways before starting any new antibiotic. That combination drastically reduces inappropriate prescribing. This slide is a great reminder of the procedural side of our role as nurse practitioners. Obviously, in skilled nursing facilities, there are some procedures we won't be doing. For example, a pap smear isn't something you're going to be performing in this environment. But many FNPs are trained and fully within their scope to provide a variety of other procedures. This includes things like joint injections, and maybe only specific joint injections, but joint injections, peg tube changes, and suprapubic catheter replacements. If it's something you're trained to do and you have done it under the direction of a physician before and it falls within your scope, you're absolutely able to perform it. That being said, scope isn't just about what's legally allowed. It's also about competence. If you've never given a joint injection before, and that would be me, it would be inappropriate to just pick up a needle and try. And I did watch several physicians do landmarking, but I never personally did it, nor would I ever without being able to do it, have someone watch me, have them coach me, and do it multiple times. In that case, it would just be expected that you receive additional training, supervision, and guidance before independently performing the procedure. The takeaway here is if it's within your scope and you're trained, you can do it. If you are not trained and you have not done it before a physician, do not do it without proper guidance. This protects you, your license, and your patients. And you can do it in front of a nurse practitioner if you've got somebody that is very skilled on doing joint injections or changing out a suprapubic catheter. It doesn't have to be a physician. It could be a physician's assistant. It could be a nurse practitioner, someone of the same area of education as you. But again, if you are not familiar with doing it, just because it's within your scope doesn't mean that it's the right thing to do. Routine lab monitoring. So this slide is a simple but really important reminder. Sometimes in the hurry of rounding or doing an initial assessment, providers order labs without doing a thorough review of the patient's diagnosis, current medications, or past lab results. Don't believe me? Look at your order for Xarelto and see what the diagnosis is. A lot of times it's anticoagulant. That's not a diagnosis. That's a classification, which is why medication reconciliation is so very important within our first evaluations of our patients. But here's the reality. In order to recognize meaningful changes in a patient's condition, you need a baseline to check and compare how they're doing. Baseline labs aren't just a box to check. They're how we identify early shifts, catch complications sooner, and make safe prescribing decisions. If we start a patient on a medication that impacts the liver, the kidneys, or electrolytes, we need to know where they're starting from. If they have a chronic condition, baseline values help us determine whether what we're seeing is new or part of their chronic picture. This is particularly important in long-term care and primary care, where we often inherit patients with fragmented medical records. Taking the time to establish or review baseline labs up front saves you time, protects the patient, and keeps your documentation defensible. Don't write, "Will obtain labs as needed," "Will monitor labs as needed." Do them. They're needed. This slide is here to remind you that our decisions around lab monitoring aren't based on personal preference. They're grounded in national standards and regulatory expectations. Multiple agencies and organizations outline when and why these labs should be obtained, both at baseline and for follow-up. So, for example, the CDC for infectious disease and vaccination guidance, including lab-based protocols. The FDA for medication labeling and monitoring recommendations. The National Institute for Health for clinical practice guidelines and evidence-based treatment standards. CMS, which sets our regulatory expectations for long-term care and skilled nursing. And JCO and IDSA and other specialty organizations for disease-specific best practices. When your documentation shows that your decisions align with these standards, it does more than just justify your care. It protects you legally, it strengthens your clinical judgment, and it keeps the facility survey ready. So when you're ordering a lab, You're not just following personal practice. You're aligning with a national evidence-based guideline and regulatory expectation. The CBC and CMP are some of the most foundational labs we use in clinical practice. They give us a broad snapshot of a patient's overall health. CBC for infection, anemia, or hematologic issues, and a CMP for liver, kidney, and electrolyte status. For new admissions or medication starts, this is your baseline anchor. It allows us to detect changes early, adjust medications appropriately, and catch complications before they turn into crises. These are also some of the most defensible labs to order in long-term care and primary care because they're evidence-based, guideline-supported, and clinically useful in almost every patient population. The TSH and the A1C are two key labs that guide how we manage some of the most chronic, common conditions we see, thyroid disease and diabetes. For a TSH, this isn't just about checking a box. Subtle changes can explain symptoms like fatigue, weight changes, cognitive decline, or mood shifts, especially in older adults. It's also essential before starting or adjusting thyroid medication. For A1C, it gives us a 3-month average of blood glucose control. In long-term care, A1C targets may be different than in younger adults. We often focus more on avoiding hypoglycemia and maintaining functional status than achieving tight control. These labs are also key for medication decisions, starting, adjusting, or deprescribing treatments. And over time, getting a baseline to track trends. Vitamin B12 and vitamin D3 are two labs that can make a big difference in patient outcomes, especially in older adults. Vitamin B12 deficiency can mimic or worsen cognitive decline, mood changes, weakness, and even neuropathy. In long-term care where these symptoms are common, having a B12 level can help differentiate between something we can fix and something we can only manage. The range for vitamin B12 is within the mid 200s to the high 8 or 900s. If you have a B12 that is within normal limits, but is in the low 200s or the 300s, you're not optimizing your vitamin B12, which again can worsen cognitive decline, mood changes, weakness, and neuropathy. So let's get a healthy vitamin B12 level. 500, 600, 700. Let's get a good number. Vitamin D3 plays a huge role in bone health, fall prevention, and immune function. And importantly, vitamin D3 is preferred over vitamin D2 because it's longer acting, more effective in maintaining therapeutic levels over time. These labs are simple to obtain, but can have a big impact on quality of life and fall prevention strategies, especially in frail or high-risk populations. A vitamin D3 level is greater than 30. If you have a D3 level of 32, you're on the very, very cusp of abnormal. Your vitamin D3 level should be in the 40, 50, 60, 70 range. We want healthy mental status, cognitive clarity, decreased level of confusion, mood issues, and we want them to be more stable. When we choose or start a statin, it's not just about putting someone on a cholesterol medication and walking away. It's about understanding the why and the what to monitor. A lipid panel at baseline gives us a clear picture of where the patient is starting. It helps determine if the statin is indicated, if the current treatment is working, or if it needs to be adjusted. SED rate and CRP can be very helpful adjunct labs, particularly in older adults or patients with multiple comorbidities. If someone develops myalgias, fatigue, or other vague symptoms after starting a statin, These inflammatory markers can help you differentiate between medication side effects, other inflammatory processes, or unrelated illness. The goal is not to overorder labs. It's to order strategically with a clear clinical purpose. That's what keeps your practice evidence-based and survey-proof. This is one of the most important lab discussions in this entire section. In long-term care, we see a lot of lower extremity edema, and the default assumption is often CHF, or it's not. It's often fluid overload. But not every swollen ankle equals heart failure. A pro-BNP and a BNP can help you differentiate between edema from venous stasis or medication side effects, simple volume overload from sodium or fluid retention, and true decompensated CHF that requires aggressive management. If a BNP or pro-BNP is elevated, it supports a CHF diagnosis, but always interpret it in context with renal function, age, and comorbidities. If it's not elevated, that's a strong signal to look for another cause rather than reflexively increasing diuretics. This lab doesn't replace a good physical exam and assessment, but it supports better decision making. It reduces inappropriate diuretic use, and it helps clarify documentation and coding. Tegretol is one of those medications where lab monitoring isn't optimal. It's essential for patient safety. Carbamazepine can affect multiple organ systems. It can affect bone marrow suppression, leading to leukopenia, agranulocytosis, and even aplastic anemia. Hepatic metabolism, meaning regular liver function monitoring, is required. Electrolyte balance, especially sodium and hyponatremia, is a common complication. And of course, serum drug levels to ensure therapeutic dosing and avoid toxicity. This is why you'll often see a front-loaded monitoring schedule, frequent CBCs, LFTs, and levels early on, and then spacing out once the stability is achieved. In long-term care and primary care, this is particularly important because patients that have comorbidities and polypharmacy increase the risk of interactions and side effects. This is a not set it and forget it medication. If you prescribe Tegretol, you must commit to structured monitoring. If the neurologist prescribes Tegretol and doesn't prescribe the monitoring, that's for you to follow. If the psych NP is using Tegretol for a mood stabilizer, this is you committing to structured monitoring. Lamotrigine doesn't require the same level of ongoing lab monitoring as some of the other seizure medications, such as Tegretol or Depakote. However, that does not mean that it's hands-off. There are still times when lab monitoring is appropriate and clinically important. For example, baseline labs such as CBC, CMP, and hepatic function are good practice, especially in medically complex or older patients. Monitoring may be warranted if the patient develops new symptoms like rash, fever, or systemic complaints that could signal a hypersensitivity reaction. If Lamictal is being used in combination with other antiepileptics, drug interactions can alter metabolism, and serum levels may be useful in some cases. Lamictal's biggest risk isn't lab-based. It's Stevens-Johnson syndrome with rapid titration or in sensitive patients. So while labs aren't frequent, clinical vigilance is essential. When I start someone on lamotrigine or Lamictal, they're always on the FDA pack, and I always have a 30-day order to monitor for Stevens-Johnson syndrome. And then under that order is what the examples of Stevens-Johnson syndrome would look like. And I have the nurses sign that off every shift. So not only am I putting the fact that they're on Lamictal and I'm going very low and slow with their dosing, but I'm bringing it to the attention of the nurses to monitor for Stevens-Johnson syndrome and then explaining exactly what Stevens-Johnson syndrome is. Keppra is one of the more straightforward seizure medications when it comes to lab monitoring. It's generally well tolerated. It doesn't require routine serum level monitoring in most cases and has fewer drug-to-drug interactions. However, that does not mean we ignore it. A baseline CMP is important since Keppra is primarily renally cleared, and dose adjustments may be necessary in patients with impaired kidney function. Periodic labs may be appropriate in patients with fluctuating renal status. Clinically, it's crucial to monitor for neuropsychiatric side effects such as mood changes, agitation, or irritability, some that are common but are often missed. Serum levels can be ordered if there are concerns about non-adherence, toxicity, or therapeutic failure. So while it's not lab heavy, Keppra still requires thoughtful insight, especially in older adults. Keppra is generally one of the easier seizure medications to manage when it comes to labs, but clinically there are a few things you need to have on your radar. One of the biggest issues I've seen in practice is behavioral and neuropsychiatric changes, particularly in patients with pre-existing schizophrenia or schizoaffective disorder or other psychotic disorders. Keppra can actually worsen agitation, irritability, confusion, and even trigger delirium-like presentation. This can easily get misinterpreted as a primary psych exacerbation, but sometimes it's actually the medication driving the symptoms. So if you're starting Keppra or increasing the dose in a patient with schizophrenia, dementia, or baseline cognitive impairment, it is critical to know their behavioral baseline and monitor closely for early changes. And again, while we don't need frequent serum levels for most patients, baseline and periodic renal function monitoring is key. Depakote is a medication that absolutely requires structured monitoring. Of course, we draw standard labs, the CBC and LFTs, and I would always say when you're drawing an LFT, draw a CMP. It gives you the kidney and the liver, it gives you the electrolytes and the protein. So I would always say defer the LFTs straight into a CMP. Because of its effect on bone marrow and liver metabolism, but one lab that often gets missed is ammonia. Depakote can increase serum ammonia levels even in patients with normal liver function. Elevated ammonia can lead to Depakote-induced hyperammonia encephalopathy, which may present as confusion, delirium, lethargy, or even psychosis in older adults. So when starting or adjusting Depakote, it's best to practice a baseline CBC, LFTs, and ammonia. Repeat at 8 days post-initiation or dose increase, especially in LTC or geriatric patients. Continue periodic monitoring every 3 months or sooner if mental status changes occur. If you've got a patient on Depakote and you've got mental status change, don't automatically assume it's a UTI. Look at the medications they're on and look to see if any of those would indicate some of their behaviors. This is critical in geriatric population where the presentation of toxicity may be subtle and easy to misattribute to dementia or a psychiatric illness. This is one of the most important and often overlooked parts of what we do as a practitioner. Care coordination isn't just about making a referral and walking away. It means actively managing the handoff to make sure the patient actually receives the care they need. For example, When referring a patient to cardiology or neurology, it's not enough to just write refer to specialists. We should clearly document the reason for referral, the urgency, any relevant labs or imaging, and what question we're asking the specialist to answer. Transition management means making sure that once a patient leaves our facility, whether that's to a hospital, another facility, or outpatient follow-up, there's a clear, structured communication about meds, diagnoses, and follow-up needs. This is also where solid documentation protects you. Why the referral or transfer was made, what your clinical thought process was, and the communication with the receiving provider occurred. We also have a YouTube training resource in the resource section that walks you step by step through how to document a full referral note to keep things clear, clean, and defensible, and also reimbursable. This is the core of why all this matters. As nurse practitioners in long-term care and primary care settings, our work doesn't exist in a vacuum. Everything we do has to align with federal and state guidelines, survey readiness, risk reduction, and interdisciplinary teamwork. Our ultimate goal is to follow CMS guidelines and maintain compliance. And you'll see almost every slide have references or URL numbers on where that information came from. It's not only that, but to help pass ACA, CMS, Joint Commission, and RAC audits, not by scrambling at the last minute, but because our documentation and care already meet the standard. Defeat and prevent litigation by providing and documenting evidence-based defensible care, and to collaborate effectively with the IDT, because care coordination and communication are at the heart of good outcomes. This isn't about making your job harder. It's about practicing smarter, protecting your license, and improving patient care. If your notes, orders, and decision-making align with CMS and evidence-based practice, you'll walk into any survey or chart review confident. This slide highlights why antibiotic stewardship is critical in long-term care. We know that antibiotics save lives when used correctly, but when they're overused or misused, they create more harm than good, especially in frail elderly patients. We're talking about C. diff, resistance, drug interactions, and survey findings. As nurse practitioners, our job isn't just to order, it's to decide if antibiotics are needed at all. That's why we rely on McGear's criteria to make sure symptoms actually meet infection thresholds. Interact care pathways to guide when to treat, monitor, or transfer. Evidence-based protocol tools such as EMRA, ABX, Sanford Guide, and Hippocrates to match the right drug, the dose, and the duration. We also need to document clearly the indication, the supporting clinical criteria, the planned course of therapy, monitoring parameters, and reassessment. Antibiotic stewardship isn't about withholding care. It's about delivering the right care to the right patient at the right time and protecting our residents, facilities, and our licensing. This slide is critical because if you only take away one prescribing safety tool, it should be McGear's criteria. McGear's criteria gives us standardized clinical triggers for diagnosing infections in long-term care residents. Why does this matter? Long-term care residents often present atypically, no fever, no clear symptoms, and overprescribing based on vague findings such as cloudy urine or a little cough is one of the biggest sources of antibiotic misuse. McGear's criteria provide objective, evidence-based thresholds for when an infection is actually likely. How to use it. Use it before prescribing antibiotics. Does the patient meet the criteria for a suspected infection? Use it as part of your documentation. Clearly note which McGear's criteria are met. Use it in combination with interact pathways to decide whether to treat in place or to escalate. If criteria aren't met, monitor. Don't reflexively treat. This protects your patient, reduces resistance, and backs up your clinical decision legally and regulatory wise. If you're ever questioned during a chart review or audit, McGear's criteria can be your clinical shield. This is where we go from, does this patient meet infection criteria, to what is the next best step for care? Once McGear's criteria confirms whether infection is likely, the Interact Care pathways guide us through structured clinical decision-making. Why does this matter in long-term care? Residents often have complex comorbidities. Not every positive lab or subtle change means hospital transfer or antibiotics. Interact gives us evidence-based pathways to support treating in place when appropriate. It helps us standardize care across providers. So whether it's me or another nurse practitioner, the decision-making framework stays the same. It also helps us avoid unnecessary transfers, which reduce the risk for patients and facility citation. Assess the McGear's criteria first to confirm the clinical threshold. Then use the relevant Interact pathway, whether UTI, respiratory, mental status change. Follow the algorithm to guide. Monitor in place, start treatment, escalate to transfer if indicated, and then document the clinical reasoning step by step. So if I'm going to pull the McGear's criteria, and I should have this attached for everyone. So under the McGear's criteria, and not each state has its own independent, so I found the latest one, and each facility may have a different form, but it is the same criteria. So whether you use this and fill this out, or whether you use this to dictate your note or to document on your note, this is what you should be utilizing. So the first one, for example, is a urinary tract infection. So a urinary tract infection without an indwelling catheter. So you must fulfill, on the left-hand side, you can see, you must fulfill both 1 and 2. So number 1 says at least one of the following sign or symptom. So you're going to have to figure out if they've met criteria for one of those. And they have to fulfill criteria too. They have to have 50,000 for an organism count, or 20,000 if it's collected from a catheter. So if you're doing a straight cath, then you would need at least 20,000. So there's comments associated with each McGear's criteria. So a UTI can be diagnosed without localizing symptoms if a blood isolate is the same as the organism, if the absence of clear alternative source of infection is there. And then it talks about urine specimens should be done as soon as possible, within 1 to 2 hours. And then if we can't get them to the lab, they get refrigerated. So this is the McGear's criteria. They've got one for urinary tract infection without a catheter, and then with a catheter. They've got one for a common cold. They've got influenza. They've got pneumonia. They've got bronchitis, cellulitis. They've got scabies, oral candidiasis. But this is a great tool. It is something that long-term care facilities utilize. ACA is going to base whether you are starting antibiotics on McGear's criteria. Every long-term care facility has an infection control preventionist, and they are filling out McGear's criteria. So while you don't have to fill out a form, your documentation should reflect that when initiating antibiotic therapy. As far as the Interact tools, there are pathways, and I'll attach that as well. Here is a pathway on acute mental status change. And so it talks about if a patient has new mental status change, then the facility would be doing an SBAR for a change of condition. And then what the expectations are of you as a nurse practitioner in order to follow this algorithm all the way through. So this is what the nurses have noted. They've figured this out. Then their next step is going to be taking vital signs. That you should know, because when they're giving you report on this patient, you should be asking for those vital signs. And then, are any of those vital signs abnormal? If no, then we're going to evaluate for other symptoms. If the vital signs are abnormal, they're going to notify us. That is us. If they notify us, then what are we doing with that information? So we're going to, if they notify us, are we going to monitor the response? Are we going to evaluate and order labs? And so this is telling the nurses to ask for these orders. They should not be asking for these orders. We should know these orders. So if you've got a patient with an altered mental status and we've got abnormal vitals, do we need to get a chest x-ray? Do we need to get a urinalysis? Do we need to get a CBC, a BMP, an EKG? And we just talked about a whole bunch of other medications that can create increased altered mental status, increased confusion, decreased mental status that we've reviewed lab-wise. So were tests ordered, and then these are the results. Like, what would make us need to respond to that? So not only are we looking at the McGear's criteria, but we're looking for specific interventions for each one of these. So this is the lower respiratory infection. The question for the nurse is that this patient has new findings. They have rhonchi or rales, they've got chest pain, they've got shortness of breath. Before they do anything else, they're to take vital signs so that they can report those vital signs to us. Then they're going to look, are any of the vital signs abnormal? If they are, then they come and report it to us. If they're not, then the nurse is going to evaluate for other symptoms. When you get that call, you're going to ask about the vital signs, and then you're going to ask, does the patient have a cough? Do they have abnormal lung sounds? And they're going to say, I don't know, and you're going to ask them to go look. Do they have any edema, a mental status change? Is there a potential for sepsis? So consider contacting the doctor. That will be us, the nurse practitioner, for an x-ray if needed, blood work, again, the CBC, the CMP, a COVID test, an influenza test, an RSV test, a strep test, some of those things that we would be looking for. And then if the tests are ordered, what are the results? And so did they give us the results? Yes. So then we have to put something in place. So if we're going to keep them in the facility, we are definitely going to want to do vital signs every 4 hours or at least every shift. Are we going to put fluids in place? Depends on how dehydrated they are. Do they need oxygen? Because this is a lower respiratory infection. So do they need oxygen? Do we need to put an SVN? Just plain albuterol, a duonib in place? We're going to consider antibiotic therapy. We're going to go back to the McGear's criteria and see if they meet criteria for an antibiotic. And then we're going to place in precautions, or the nurses are. So our portion of this is this, but we need to know what the expectation is of the nurse and what they're looking for so that we can follow through with that as well. So I think there's 9 or 10 different pathways. The McGear's criteria are all on one flowing document. So you will get a copy of that with this slide. Very important to have, very important to use, very important to use while you're doing your documentation. So these are the different care pathways: acute mental status change, behavioral changes, dehydration, fever, GI symptoms, shortness of breath, CHF, lower respiratory illness, UTIs, and falls. So while it seems like they're giving you the answers, they're giving you the clear care pathways, the answers, it's because as a country, we all try to follow evidence-based practice, evidence-based protocols. And as nurse practitioners, as a profession in the country, we're going to be doing the same thing. So no longer are we going, oh, well, I did it this way at my facility. No, we're going to be following those protocols that verify when the doctor comes in and sees our note, that our note actually has the right dosage, the right strength, the right route, the right reason we started them on that. And the reason is going to be your documentation. Not patient has a cough and we started them on antibiotics, but follow that McGear's criteria, that they are appropriate, draw the labs that need to be obtained, and then we can follow through with that. Before you write an order or click e-prescribe, putting it in point click care, pause and think critically. Prescribing is not a reflex. It's a clinical decision that has a ripple effect on your patient, your facility, and your license. So here's what the pause should include. What is the problem? Are the symptoms acute? Are they chronic or unclear? Are we treating a real condition or just a lab value? Does the patient meet criteria, especially for infections, pain medications, or controlled substances? What's their history and comorbidities? Could this medication worsen another condition? For example, congestive heart failure, delirium, renal impairment. What's already on their medication list? Think interactions, duplication, and polypharmacy. Don't always think of putting a new med in place. Maybe it's taking a medication out. What monitoring will be required? Labs, side effects, follow-ups. What's the de-prescribing plan, especially for antibiotics, opioids, psychotropics, or short-term agents? This quick clinical gut check is how we protect patients and ourselves. Remember, your DEA, your license, the facility, they can all be impacted based on one single unsafe prescription. But more importantly, so can the patient's quality of life. This slide speaks to a reality that many of us see every day. We often don't order what we should, not because we don't know better, but because of workflow, pressure, or old habits. Here are some common pitfalls I want us to reflect on as prescribers. Assuming someone else already ordered it. This happens all the time with labs or consults. In reality, the patient goes weeks without appropriate monitoring. Ordering based on old patterns, not evidence. We always do this. Isn't a clinical justification. If it's not supported by evidence-based practice, it may not be appropriate anymore. Avoiding orders to not rock the boat, especially in facilities with strong personalities or resistance to change. It's easy to default to minimal intervention. That's not safe medicine. Lack of clear ownership. When the MD, nurse practitioner, and IDT all think someone else is responsible, the patient falls through the cracks. Do you remember the patient that had a TSH that we found from 6 months ago and it was 13? And throughout that whole 6 months, nobody addressed it. And we're now the new nurse practitioner in the facility. We're doing a chart review. We find the thyroid that says it's 13, and nowhere can we find any synthroid. Nowhere can we find a repeat TSH. Nowhere can we find a thyroid panel. Good intentions, but us finding something. We have to take accountability. These are our patients Monday through Friday. A lot of facilities have weekend providers. This is what we are meant to do. That meticulous audit to make sure that all aspects of a patient care is taken care of. Fear of over ordering or getting dinged for cost. Remember, appropriate monitoring is not over ordering. It's good clinical care and defensible in audits. Now, I have seen some that just have routine labs every 3 months, and in those labs are like a lipid panel. And why would you do a lipid panel more than once a year if the lipid panel is stable? A patient that's not diabetic that we did a one-time A1C, and now they're getting it every 3 months. So over ordering, as long as it's appropriate, is good clinical care. Our job is to stand confidently in evidence-based practice. If baseline labs are needed, if monitoring is required, if consult is warranted, order it. Document why. That's what protects the patient and your license. I know this was a lot of time out of your day. I hope that it makes you feel a little bit stronger in the role you play in all of our facilities. I hope it makes you feel that there are evidence-based protocols out there in a wide variety of mobile apps, desktop apps that we can always reference and go back and look. I hope it makes us feel when we put a medication in place and we have strong personalities, such as a physician or a physician's PA or NP, that come in and discontinue our order, that we can justifiably say, this was the right medication for the right patient at the right time. I did my research. Here is my documentation, which is thorough and meticulous. And I want to know what was wrong that you changed it from this to this. I followed McGear's criteria. I followed the algorithms. What was wrong? And in reality, when your documentation and your evidence-based practice is there, those questions won't be asked. Those orders won't be discontinued. Strong physician or not, strong personalities or not, we're doing the right thing at the right time for the right reason, and it's for the patient. That's what we have been called to do, and I hope going forward we have a little more confidence in what we do. We have more options of where to go to get that information. And if you ever have a question about what has been done, what you have ordered, why something has been discontinued, text me, email me, let me know. Everyone knows that I'm busy, and everyone knows that I'm never too busy for you, and I'm never too busy for a question. Utilize the WhatsApp chat. Utilize the ability of 80 plus minds coming together on that app to ask evidence-based practice questions. And I hope as we go forward today, we come together as a united nurse practitioner team, and that we're able to make those strong decisions and be able to be a better resource for our facilities. I want you to have a great day.